Hello and welcome to the RCSI My Health series. My name is Professor Suzanne McDonough and today we're going to be discussing diabetes, prevention, treatment and supports. The series explores a wide range of areas of health and well-being and brings together leading healthcare experts across these fields with the goal of empowering people with the knowledge to make informed decisions about their own health and well-being. The series was recently announced as a winner of the Best of Europe Region 2024 by CASE, the Council for Advancement and Support of Education. Today I'm joined by Dr. Kate Gajewska, Clinical Manager for Advocacy and Research, Diabetes Ireland, Professor Edward Gregg, Head, School of Population Health, RCSI University of Medicine and Health Sciences, Professor Diarmuid Smith, Consultant Endocrinologist, Beaumont Hospital, Professor Seamus Shreenan, Director, Graduate Entry Medicine Programme, RCSI University of Medicine and Health Sciences, and Consultant in Diabetes and Endocrinology at Connolly Hospital, Blanchardstown in Dublin. So thanks everybody for joining us today to have this discussion. So we're going to start with you, Ed. How significant is the burden of diabetes from a public health perspective?
Well, there's no question that it's a significant burden. It's one of the biggest problems we're actually confronted with right now for a few reasons. It's very common now. About 12% of adults in the world now have diabetes. It's growing. It's in Ireland, the prevalence has more than doubled in the last 20 years. And it's really damaging, and diabetes really does its damage through multiple organ systems of the body. It affects our vascular system, our muscles, our brain, our nerves, and all these collectively lead to a whole range of complications that affect quality of life and disability. So this is a problem that we really want to affect and make a difference on.
Great. And what do the latest epidemiological trends tell us about the impact of type 1 and type 2 diabetes?
Well, it's actually a combination of some good news and bad news there. If you look actually at the long term, there's been a remarkable reduction in the rates of complications. So the average person with diabetes now has actually only about half the chance of developing a new complication than their counterpart did one generation ago. And that's really a testament to really improvements in care and understanding of the condition. So in that sense, it's actually been a big success. The problem is that that's really started from a very poor status, and we still have a situation where much of chronic diseases that result from diabetes can be prevented. And we're also seeing additional compounding problems like earlier onset of diabetes. And when people develop, when I say early onset, even in young adulthood, and we think of when people develop diabetes in their 20s and 30s, it tends to be come with a lot of other risk factors that affect other conditions. And the other thing that we're seeing is that because there's actually been a remarkable improvement in lifespans, people live much longer with diabetes, that's actually more time to accumulate conditions. So it's become more complex condition for clinicians like my colleagues here. All that said, I'll turn back to a bit of good news. There's I think a lot in terms of new treatments, new understanding of prevention, and the development of new technology that can really make a difference.
So you mentioned there about the growing problem in younger people, and could you maybe just explain what maybe is driving that increase?
Well, I think a lot of this has to do with the society and the environments that we live in. And there certainly has been the last generation had prevalence of obesity really higher than previous generations, really than ever before. That's certainly been a big factor. And in addition to that, though, young people don't necessarily have the same access to care and the same continuity of care. So when they're diagnosed, they don't necessarily get the same management that we know actually really works as older people. So that's an additional problem there.
That's great. Thanks very much for that. So moving to you, Diarmuid, maybe you could explain to the audience listening, how does type 1 diabetes differ from type 2 diabetes? And how does it vary in its progression and cause?
Yeah, so thanks, Suzanne. So essentially type 1 diabetes probably affects about 25,000 Irish people. And type 1 diabetes can happen at any time in life, but typically presents in young children, usually around the age of 2 to 4 years, puberty or early 20s. Can happen though at any time. Mm-hmm. Now with type 1 diabetes, you're born with a genetic predisposition to developing it. and then antibodies are generated within your body. And antibodies are cells produced by your own body. And we're not sure why they're generated. And those antibodies can sit there for a long period of time, and eventually some trigger comes along where they can generate an immune response that attacks the pancreas and attacks the cells of the pancreas that produce insulin. And that immune response can destroy the cells of the pancreas that produce insulin. And so in type 1 diabetes, typically they require treatment with insulin, which we typically give either as injections or via an insulin pump. Type 2 diabetes is a more common type of diabetes. And that probably affects maybe about 300,000 people in Ireland with diabetes. Again, we're not sure of the absolute number. And type 2 diabetes, again, can happen at any time in life, but usually it's in the older population. But as Ed mentioned, we're seeing it now happening in a much younger population, typically now presenting maybe in the 4th or 5th decade of life. In type 2 diabetes, again, you're born with a genetic predisposition, and this genetic predisposition is to a thing called insulin resistance. Now, the function of insulin is to take sugar or glucose from your circulation and put it in your muscle and your liver where it's stored as an energy store. But from birth with type 2 diabetes, your muscle and liver can ignore that insulin signal. So your pancreas has to produce more insulin to overcome that signal. Then over time, with the additional effects of lifestyle that can worsen the insulin resistance, your pancreas then hits a stage where it sort of says, I can't do this anymore. I can't keep up. I can't produce enough insulin to keep your sugars normal. And so the cells of the pancreas that produce insulin, the beta cell, then start to fail. They start to reduce their number. And so when you get a combination then of insulin resistance and not producing enough insulin, that's when you develop type 2 diabetes. And the problem with type 2 diabetes is even after diagnosis, the insulin producing cell can continue to fail. But type 2 diabetes can be managed with diet, exercise, lifestyle, or can be managed with tablets. But unfortunately, a significant proportion of people with type 2 diabetes do also end up on insulin.
Great, thanks for that. So you talked about type 1 diabetes commonly presents in children, but it can present in adults. So is there a difference in how it presents in children versus adults?
Yeah, and this is something that's, I think, getting a lot of attention in the diabetes literature more recently, that there's maybe 2 subtypes of type 1 diabetes. Subtype 1 is typically what the diabetes, how type 1 diabetes presents in young children, typically less than 8 years of age. And then subtype 2 is in the older adult. Now, in the young child, typically, again, the antibodies are generated early in life, and again, we're not sure why that is. And those antibodies can trigger a very aggressive immune response that can very rapidly destroy the cells of the pancreas that produce insulin. And so those children can often present in extremis in a thing called diabetic ketoacidosis, which is a medical emergency, and those children will need to go on insulin straight away as their treatment. In the adult, it's more of a different presentation frequently. And often we find that sometimes in an adult, they can often maybe be misdiagnosed as having type 2 diabetes when actually they have more type 1 diabetes. So it's a slower destruction of the cells of the pancreas. So the antibodies can be there, but it's a slower destruction of the cells of the pancreas. So they often may be mislabeled with their diagnosis, but actually instead of being, they might have been called a type 2 diabetic, but actually they're a type 1. And frequently they too will end up on insulin, but it's a slower process.
So could you maybe talk to us then, Dermot, about what are some of the most exciting advancements in type 1 diabetes treatment?
So I think in treatment-wise, the field we're in, and I think Ed touched on it, there's a huge amount of work being done in diabetes, and the work that has been done has made huge improvements to improving diabetes control and reducing complications for people, which is fantastic. And probably one of the biggest advances that we're seeing in our clinical practice is technology and the use of insulin pumps and continuous sensors. So back in the 70s, people were testing the urine for glucose. And then there was the advancement of checking a finger prick to check your blood glucose. And now we have these things called continuous glucose sensors, which is a device that is worn that doesn't measure blood glucose. It measures an equivalent of blood glucose called interstitial glucose. And these sensors can give maybe 250 to 500 readings a day. So it gives a continuous profile during the daytime and at nighttime. And so particularly in young children, it allows the parents to get better control and a better understanding of their child's blood sugars throughout a 24-hour period. The sensors will also have alarms. So they will alarm if you're going too low, or they will alarm if you're going too high. And part of our role as clinicians is then to educate the child and the parent and the adult about what to do in those settings. We also now have a thing called insulin pumps, which is a continuous delivery system where you wear a pump, which is a device which delivers insulin every couple of minutes in a subcutaneous fashion. And the sensors can talk to the pump. So the sensor can take what the reading is and tell the pump what insulin to deliver. And so if the glucose level is going too low, then the sensor can tell the pump to stop delivering the insulin. If the sugars are going too high, the new pumps can now deliver a little correction dose of insulin. And they're what we call hybrid closed loops. So they're not a fully closed loop. In the diabetes world, we talk about this technology of like an electronic pancreas. So these pumps are nearly there, but they're not fully there. So the patient still has to, or the person with diabetes still has to decide on how much insulin to take with food, etc. But the technology is evolving where the sensors are getting better, they're getting more accurate, they're getting more reliable, more robust, and the pumps are getting smaller, more accurate, more reliable, and people are trying to work towards a fully electronic pancreas.
Fantastic. Thanks very much for that. So I might move on to you, Kate, if that's okay. So obviously you're someone living with diabetes. So what would you say are the most challenging aspects of living with type 1 diabetes?
So I'll start from the fact that diabetes is just continuous. It's 24/7. It's 365 days a year. There's no break. And it's one of the few, or maybe one and only condition where every thing that you do affects your glucose levels. So it affects the way how you manage it, and you have to be continuously prepared. So it's every day a person with diabetes has to make multiple medical decisions about insulin dosing, about checking glucose levels, about reacting to hypo or hyperglycemia, or to prevent those. You have to always be ready for everything. So even before this this meeting, I had to check my level. I had to take my hypo treatment. I have it with me here. So I always have to plan in advance. So that's tough for many. Another challenge, I think one of the most challenging times, is when you're diagnosed with diabetes, because your life is changing dramatically. You can't be just, you can't just let go and just do things. You have to think, you have to learn how to live with diabetes, which is not easy. Dermot mentioned all these fantastic technologies available, but you also have to learn how to use it, how to react, how to manage diabetes, how to manage it all. So it's very hard for families. It might be very hard for parents of little children with diabetes who are diagnosed. There is a lot of burden associated with living with diabetes. Diabetes distress. People are more frequently diagnosed with depression if they have type 1 diabetes than people who don't have it. It's just burdensome.
Great. So thanks very much for that. And just out of interest, I mean, what age were you when you got your diagnosis? It's just wondering how long you've had to learn to manage it.
It's April. So I was diagnosed in April 1987. So it was 38 years ago.
Okay.
Yes.
Yeah. So I'd imagine during that time you've probably seen huge changes. I mean, Gerbert's talked about the changing technology and treatments. You've probably seen massive changes.
Yes, absolutely. The treatment has changed in a dramatic way. So when I was diagnosed as a little child, of course I can't remember it because I was only 16 months old, but there were no blood glucose meters at all. So my parents had to check my urine to check whether I have glucose in the urine or not. They were only aware whether I have hyperglycemia, but they were not aware whether I have hypoglycemia because it doesn't show whether your sugars are low. So yeah, no blood glucose meters, no modern insulins that we now use, analog insulins. Diet was the main way of treating diabetes. Insulin twice a day, and diet 6 meals a day, every day the same amount of food, the same things. It was just very hard for a small child to be so strict when it comes to diet. So, so then when newer insulins were on the market, that made a change, made a huge difference, because instead of treating diabetes with diet, we were able to decide on insulin dose based on what I would like to eat or not. We call it dose adjusting for normal eating. There's a special diabetes education program like this. So you dose your insulin when you want to eat and what you are willing to eat. So you check your glucose levels, you inject insulin. Then the next fantastic technological advance was insulin pump. I am on pump since 2020. No, 2000, sorry, so it's 25 years now that I'm using insulin pump, and it's really changed the way how I live with diabetes. It gave me a lot more spontaneity and a lot more flexibility. I felt just a lot more normal when compared to my peers. And then continuous glucose monitoring, it's a game changer. It's absolute game changer for everyone living with type 1 diabetes, because finally, instead of checking glucose levels from time to time every couple of hours and just switching the lights on for a second, you just know what's happening. You just have your lights on. You know exactly where your glucose level is going, whether it's rising, whether it's going down, and you can adapt your decisions and whatever you need to do. And then finally, hybrid closed loop systems or artificial pancreas systems. That's another game changer. It's insulin is delivered automatically, so many of those medical decisions that we need to make is taken from us, so we don't have to do it anymore, but we still have to make a few. So as Dermot mentioned, we have to inform the system what are we going to eat, so how much carbs are we going to eat. We need to inform the system whether we are going to exercise or not, but the automated insulin delivery system works absolutely fantastic for all people with type 1 diabetes. The issue, and that's coming back to challenges, is that access is quite poor when it comes to using technology, so not the majority of people with type 1 diabetes would be using it, actually minority.
And is that in Ireland or globally?
In Ireland and globally, but there are differences in different countries. So in some countries, for example, in Germany, almost all children would be using insulin pumps, whereas in Ireland, a half of pediatric population would be using pumps. So when it comes to adults, 1/3 of adults would be using pumps in Germany, whereas in Ireland, it's around 10%, maybe less. So there are differences, there are different countries, of course, but yeah, access is a thing, and I know that Seamus and Dermot know it very well.
Yeah, that's great.
It's interesting when you chat to someone who's had diabetes for a long time and you ask them, what do you think is the greatest advance? A lot of them will say the continuous glucose monitoring, that is just being transformative. And yet when you ask maybe someone who's just been diagnosed and so they think continuous glucose monitoring is the norm, they're like, oh, so, you know, it's you know, so can you not make it easier? So, but it is for people who've had diabetes a long time and they've seen those advances, continuous glucose monitoring has been transformative.
Or even the old pumps, the original pumps were very complicated to actually program. I think only a selected, you probably did it, but you were probably in a minority of actually using a pump because they were difficult.
Yes, and they were super expensive, of course. So that was a big financial burden to get a pump. And I just have to say that we are very lucky in Ireland that actually people do not have to pay for technology if they have it. But yeah, and it's not the case in every even European country. So so that's something we need to always remember. But yes, old insulin pumps, the first insulin pumps were like big backpacks. They were like, I think it was 60s or 70s, and then they were just getting smaller and smaller. But yeah, it was difficult to learn how to use it because no one knew how to use it really. So I learned very hard lessons with the insulin pump, and I also learned that I always have to be prepared when it comes to any issues or alerts, or that the pump may break because it's just a technology. So I always have my insulin pens whenever I go, just in case. Yeah, and I advise everyone to have it. We love technology, but we also have to make sure that it works.
So thanks for that, Kate. So Seamus, moving over to you, could you maybe talk to us about the most promising advancements in type 2 diabetes, including drugs and technologies?
Okay, thanks, Suzanne. So it's quite a different condition, as Diarmuid has already mentioned, and we've talked about the changes over the last 30 years in type 1 diabetes. Well, I've been in diabetes for that duration, and it's been transformative, really, from the therapeutic standpoint in type 2 diabetes. So when I went to medical school, there were a couple of types of medication tablets you could use if you needed tablets for diabetes, and then you were moving on to insulin. But in the last 20, 30, 25 years, the number of medications, a variety of medications that have become available for type 2 diabetes have really made managing the condition so much easier and so much better for people living with diabetes. And where we are now, we're in a time of real change, and treatments that are becoming available that not only can manage the blood sugar, but can also provide additional benefits for people living with type 2 diabetes. So many people who have type 2 diabetes struggle with their weight, and now we have medications that can bring the sugar down, but also help by bringing the weight down. We also have medications that help reduce some of the complications. So the treatments that we have now reduce blood sugar, but also can reduce the complications that both Ed and Diarmuid have already talked about. And of course, that's really where we want to be with managing diabetes, not only to control the blood sugar, but to prevent the long-term complications. And I think looking ahead over the next 5 to 10 years, I think we're going to see a lot more novel treatments becoming available that will really be transformative for people living with diabetes. So that's really from the treatment standpoint. From the technology standpoint, so as Diarmuid said, type 2 diabetes often it tends to affect people who are a little bit older, a little bit further on in life. And I suppose by their nature, some of those people currently in the 60s and 70s might not embrace technology to the same extent as younger people who have type 1 diabetes. So it's very individual, I would say. Where we are with technology, I think there's no reason why the technology that works for type 1 diabetes will not work for type 2 diabetes. And that's what actually I'd like to see for people who are on insulin, for example. Diarmuid mentioned that some people with type 2 diabetes eventually progress to the stage where they need insulin to control their condition. And certainly in Ireland at the moment, the technologies that are available for type 1 diabetes are not reimbursed. In other words, the person is not entitled under the national reimbursement program to avail of those treatments, so they would have to, or those technologies, they have to pay for them themselves. Okay. And we know that a substantial number of our people with type 2 diabetes on insulin are not able to access those treatments or those technologies currently.
So I know Diarmuid said, certainly for type 2 diabetes, that lifestyle management was part of it. So could you maybe talk to us about, lifestyle related apps and what's your experience of either advising people or people, using those for management?
So I suppose from the research standpoint, there has been quite a number of studies. I suppose they're quite heterogeneous, so they're very different. They're in different populations. And so if you look at the research to determine the benefit, it's probably quite modest. There's definitely benefits, I think, from apps, lifestyle apps for bringing down HbA1c to a small degree. That's the test we use to tell whether the blood sugars are controlled or not, and also some benefits in weight. But when you're looking at preventing complications in type 2 diabetes, you also have to consider blood pressure, you also have to consider the cholesterol, and there's less evidence that the lifestyle apps benefit people in that regard. So again, it's very individual. I think if somebody's going to benefit from an app, it needs to be something that's going to suit their needs. So you really need to talk to the individual, ask what they would expect to gain from an app and how that might help them, and then maybe pick an app that's tailored to their needs. And so maybe in the era of AI now we can have automated, tailored feedback based on the information that's been provided by apps to individuals, and that really might be more beneficial. And I suppose, again, elderly people might not avail of an app. It's more the younger people with type 2 diabetes, I think, will embrace that technology. And I suppose one of the areas that are really thinking on a grander scale, international scale, there are many countries where there's very little support for people living with diabetes. They don't have access to DAFNE, the education programs. They don't have access to diabetes centres, but most people probably have a phone. And I think in under low-income countries, or even people in lower socioeconomic groups in middle-income and higher-income countries who can't avail of the services for diabetes, having an app on their phone that might be the only feedback and help they're getting to manage their diabetes. I think that's a potential area where they could be very helpful, but we don't really have much research in that space currently.
And I expect that's going to change hugely in the next 5 years, given with all the advances in technology. So it'll be interesting to see what happens.
Exactly.
Yeah. Thanks very much for that, Seamus. So, Kate, I'm going to move back to you. So, obviously, you've talked about your own personal experiences with type 1 diabetes, but you obviously work for Diabetes Ireland. So, could you maybe talk to us about the major challenges or complications that you hear about from people who've got type 2 diabetes?
Yes, absolutely. I will start from the fact that many people, if they call us, if they reach out to Diabetes Ireland, they feel quite lonely when it comes to this diagnosis. They don't know what to do, because type 2 diabetes is usually diagnosed in a GP practice. They feel that they don't receive enough information, or they are just being told, oh, you need to lose weight and you need to change your life, and that's it. So that's what people complain about, and that's what we hear very, very often, that they are told what to do, but they don't really know how. So that's why there are many educational programs for people with type 2 diabetes, and we have fantastic now initiative. I'm talking about integrated model of care and community hubs, where there is a special support offered for people who are diagnosed with type 2 diabetes or experience any complications, where they can have an appointment with a dietitian, with a diabetes nurse specialist. So the care is moving from hospital care to specialist community hubs, which is great. But one of the challenges which we hear from people is that not all of them have access to it in terms of, again, GP. We have to pay for GP practice. Only people who have medical cards are eligible to be as part of the program. They can be referred to the community hubs, even if they pay for the GP visits, but then the whole care as a project in terms of blood tests or appointments or annual reviews with a GP, that's something that they have to pay for. So that's one of the challenges what people complain about. And then another thing that people complain is this psychological burden and stigma and judgment that is associated with diabetes, because let's be honest, diabetes is not a fancy condition from that point of view. Many people hear, oh, you did it to yourself because that was your lifestyle. Yeah, oh, you shouldn't have eaten all those sweets when you were younger, and that's all your fault. That's how people feel. They self-blame each other, but they also hear it from their friends, from their family, from healthcare professionals as well, unfortunately. So that contributes to the burden, and then it's hard to change your lifestyle. Then you know that you're failing if you're not doing well and you're not doing what you were asked for. So it's a constant circle of self-blame and stigma. So these are the two main things that people complain about. And yeah, we're very sorry when we hear that, because it happens all the time.
And what kind of, I mean, is Diabetes Ireland able to provide some support for people, particularly when they're going through that sort of psychological burden? Yes,
absolutely. We have a healthcare professional team. We have our support educators who are providing CODE, which is our diabetes structured education program. It is available for everyone. It's online, so you don't even have to have a referral. You can just sign up. We have Smart Education program, which is an online education, but it's not grouped. It's a computer-based, e-learning-based type of program, so you can learn about diabetes, the basics about diabetes yourself in your own time at your own pace. We also develop well-being and mental health support programs. We are finalizing our pilot sessions focusing on coping strategies, on stigma, on self-advocating, on compassion and self-compassion. The feedback so far is absolutely fantastic from people who attend it. So we would like to roll roll it out to all people with type 2 diabetes when we are ready. We also develop similar programs for people with type 1 diabetes, adults, newly diagnosed adults with type 1 diabetes, and for families, so for parents of children with diabetes. So there's a lot of resources on the website, so please just visit www.diabetes.ie. We have a community of volunteers, of people who are there to support other people with diabetes. So just join us maybe, or use what we have, because there's loads.
Do you mind if I just
Absolutely,
add in there,
do
Suzanne?
come in,
I
yeah.
think Kate's touched on a very important point when someone's diagnosed with type 2 diabetes, is to say to them from the start that, you know, they were born with a genetic predisposition to developing this condition, because there is a lot of stigma attached around type 2 diabetes. The other point, I think, is to educate people that it's not a static condition. So if you come to me today and your type 2 diabetes is well controlled, it doesn't mean it's going to be well controlled in 12 months' time or 24 months' time. You need to continue to keep going to see your GP or the hospital, specialist hospital services, wherever it is. You need to keep coming back, because as we've mentioned before, this is a progressive failure of the cells of the pancreas that produce insulin. So your sugars might be good today, but not necessarily in 2 years' time or 3 years' time. And the last thing, just to touch on Seamus's point, the advances in type 2 diabetes have been incredible from a medication point of view. Like, the treatment algorithm for type 2 diabetes has been transformed over the last decade. And the medications we have for type 2 diabetes are so good, now we're using them in for non-diabetics who have heart problems or liver problems. Our medications are so good, non-diabetics are taking it. And also there's research going on where maybe some of the type 2 diabetes medications may complement insulin treatment in type 1. So that's a field of research that we'll see some maybe more results in the next 5 or 10 years.
Brilliant. So that kind of feeds into my next question, which is for everybody in the panel. So to all of you, what does the future hold for diabetes treatment and management?
From type 1 diabetes, I'd say it's technology, more and more advanced technology, because we see the progress with, let's say, mobile phones. They're changing dramatically every couple of years, and that's what we will see in terms of treating type 1 diabetes. So fully closed loop systems, so systems that doesn't require any input from the person living with diabetes, which would be fully artificial pancreas, so something just that I have here, but it just works for me and I don't have to think about anything else. That's something what we would like to see, and there is research ongoing, so plenty of. So another thing from the type 1 perspective would be there's work ongoing on smart insulin, so the insulin that is active only when the glucose level is increasing, so it works automatically. You inject it, but it just works when it should work, which would also be a big game changer if it works, of course. Anything else?
Yeah, no, I suppose maybe we'll go around this way, will we?
Whatever way.
So
yeah.
I would be interested, as I mentioned before, with the type 1 diabetes. Again, you're born with this genetic predisposition, and then antibodies, which are cells your own body produces, appear in your system. And the question is why? Why does that happen? And I think that is a huge field of research in diabetes, to try and figure out why that is, because it happens very early in life. So is it a viral infection? Is it something else? We're not sure. And then in some people, the antibodies can sit there and may do nothing. They just sit there all life or disappear. While in other people, they then start to attack the pancreas. And as they attack the pancreas, again, the speed at which they attack the pancreas varies dependent maybe on your age. And so now there's a lot of research to sort of say, well, in people who have these antibodies, can we give them medications that we call immunotherapies that maybe could prevent them developing type 1 diabetes, or slow down the absolute destruction of the cells of the pancreas that produce insulin? So I think that's another exciting field of research that we're going to see huge developments on in the next number of years.
Thank you very much for that, Dermot. So Seamus, I might go to you and then to Ed, if that's all right. Yeah.
Yeah, no, I'd agree with Dermot. I think one of the most exciting areas is this, the potential for immunotherapy. And we actually have therapies now that we know, if you get in early after diagnosis, that you can retard the progression of type 1 diabetes. The research that's been done to date really has been using one immunotherapy at a time. And I think where we really need to go is to use different types of immunotherapy that target different parts of the immune system, and maybe use them together. Maybe combining 2 or 3 different treatments and then seeing where we get in terms of preventing the progression. And to go back then and take people who have antibodies only and haven't actually developed diabetes yet, that's, I suppose, we need to understand who amongst those are those likely to progress. So we know that if you have more than one of the antibodies that Dermot mentioned, then you're much more likely. And if you have 2, 3 or 4 antibodies, well then almost certainly you're going to get type 1 diabetes in a very short period of time. And that would be, I suppose, goal, to be able to prove that you could prevent type 1 diabetes from starting in the first place. On the subject of prevention, I suppose, in type 2 diabetes, we know that we can prevent type 2 diabetes. And what I'd like to see to develop here in Ireland is a diabetes prevention program. And I know there are people working on designing and hopefully developing a diabetes prevention program. We know from research from the US and other countries that if you, just with lifestyle intervention, some of what we talked about, that you can prevent the development of type 2 diabetes. And this is, you mentioned apps earlier, I think that's something where an app could come in again, because the studies have shown that you need constant reinforcement. The more one-to-one feedback you have with individuals who are going to encourage you to maintain the lifestyle interventions that are beneficial, that's what's going to be make the prevention program work. And so I think apps could actually be helpful in that setting too.
Brilliant, thank you. And then Ed, I know you're probably very focused on prevention, so maybe you'd like to...
Well, before that, I'd like to say that the things that us studying the epidemiology are interested to see is when we talk about these really amazing changes just in the very recent past, in the last 10 years, is that step down, that big reduction in complications that we saw back in the 2000s, and then actually things actually stalled a bit. Are we going to see another step down in the coming years? That's question one, and is that going to affect all complications? The big reductions in the past were really in heart disease, stroke, and amputation, but are we going to see effects on renal disease as well, and other neuropathy and such? But then the second question is that going to affect the whole population? One problem with the development of new technologies and new drugs is that often they end up getting distributed to subsets, and they don't, and there are groups of the population that don't get that, and so you can have reductions in overall rates that are just driven by a subgroup, and that's what we don't want to see, of course.
Great, thanks very much for that. This is to Dermot and Seamus. So is there potential for a cure for diabetes, or can it be prevented or reversed?
So we touch upon maybe the immunotherapy to try and perceive we can prevent or slow down the death of the pancreatic beta cell in people with type 1 diabetes. And I suppose then as regards to cure, then that touches upon transplantation. And transplantation comes in very different formats, where you can maybe transplant a pancreas. And if you transplant a pancreas into someone with type 1 diabetes, that can of course normalize the blood glucose levels. You're off insulin, but you're on immunosuppressants for the rest of your life to dampen down your immune system. We then had a field of a thing called islet cell transplantation, where the islet cells, just the islets that produce insulin, were taken out of a donor pancreas and injected back into the liver of someone with type 1 diabetes. And that did help reduce frequency of hypoglycemia and maybe reduce the need for insulin for periods of time. But again, people were on immunosuppressants, and immunosuppressants do have complications and side effects associated with it. So a lot of the research now focusing on stem cell, where you can take a cell from a different part of your body, and that cell could be from your own person, and then you modify or change that cell so that it becomes a beta cell of the pancreas, and that you could inject that into the person with type 1 diabetes, and then that would hopefully cure the type 1 diabetes, or the person will be off insulin. And that is work ongoing, and there has been promising data with that. And I think recently this year there was a patient from China who had a stem cell transplantation who ended up off insulin, or is still off insulin 1 year after the treatment. Now that's one person. So a lot more work needs to be done in that field. But the idea of a stem cell transplant, where you take a cell from your own body, would mean that you would not necessarily need to have immunosuppression. So there is work ongoing with stem cells where there is immunosuppression involved, or maybe not involved. And that is, without question, a field that's going to evolve, and more data coming out in the next decade or so.
Great. And how far away do you think? Is it a decade?
I think we're still a long way away from it. I still think Probably, yeah, I think over the next, maybe it's going to take another 10 to 15 years before we can definitively say this treatment is working or not working. So we only have a handful, and people maybe jump ahead and get very excited and say a cure is coming. We still have a long way to go with that.
I'm just laughing here, sorry, because in my almost 40 years living with diabetes, I'll be very honest, I'm quite skeptical when it comes to when we will find a cure. But there is a lot of research ongoing, and we are definitely in a lot better place now than we were 10 years ago or 20 years ago. I would not say it's 10 years, I would say it might be even 50, but I think it's coming. It's just a matter of time.
Thanks for that, Kate. And then Seamus, from your perspective, what about type 2 diabetes?
So yeah, I think type 2 diabetes, we probably would consider that once you have it, you're never really cured of it. But there's no doubt about it, you can go into what we would say is a remission. And a lot of the work that has proven that has been on quite strict diets. So research that came out of the UK about 5 or 6 years ago showing that people who went after a diagnosis of type 2 diabetes went on a very strict calorie controlled diet where they only consumed about 600 calories a day. Their blood sugars reverted to normal very quickly. The problem is that maintaining that kind of a dietary restriction to stay in remission is very challenging. And so over time, as people naturally started to eat a little bit more and the calorie consumption increased, then in some of those people, the diabetes re-emerged. And so if people do lose a significant amount of weight through lifestyle interventions or other treatments, then there's no doubt that they can go into remission, but we would probably say that they're not cured as such in the way that we talk about a potential cure for type 1 diabetes.
Okay, thanks very much for that, Seamus. So my next question is to everybody in the panel, so you can have a think about this one. So what practical steps can individuals take to effectively manage their diabetes and improve their quality of life? And maybe Kate, you might.
Yes, okay. So I'll start is the one step at a time. I think it's a good advice because it's very overwhelming to receive all this information, what you have to do to manage it well. You have to do this, you have to do that, da, 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 da. And it might be very burdensome for many and overwhelming. So start from something small. Okay, that's something that I could improve. My next goal in the next 2 weeks will be, okay, I'll eat one slice of bread less, then I'll eat something, then I introduce exercise, etc. So good planning and small steps are really helping instead of changing everything all at once, because then it's very hard to maintain it. Like Seamus said, this 600 calorie diet, it must be tough to start the diet just from now. You can survive 2 weeks, but then you're just waiting, okay, when can I stop this? So yeah, one step at a time. Remember that change is a slow process, and just be proactive. I think it's extremely important for people who are diagnosed with diabetes, who live with diabetes, to be the experts in their condition. So it's a very specific type of condition that it really depends, your outcomes really depend on you. It's not just a tablet a day, it really depends on what you're doing. So that's why you have to know what happens in your body, how different food affects your blood glucose levels, how exercise affects it, what can you do to improve it. So attend your education programs, ask your healthcare professionals, ask your diabetes teams or GP what options are out there when it comes to different treatments, when it comes to diabetes technology, etc. And just remember that, living is sometimes more important than just living with diabetes, because what we also see is people who are perfectionists and they completely focus on having perfect glucose levels. It's also not the case, because it's also very burdensome if you do that. You have to live, but you just have to learn how to live your life with diabetes and just don't give up. So yeah, a few tips. And mind your mental health and well-being. If you need help, reach out to your diabetes team or your GP. Say that you need psychology, or you need to be seen by a psychiatrist, or if you want, just reach out to other people who have diabetes. Reach out to Diabetes Island, and we're all there to help.
That's brilliant. Thanks very much. So,
yeah, I suppose for my tips for somebody with type 1 diabetes is, first of all, to say it's not your fault. This wasn't your fault. You didn't do anything wrong. This, again, genetic condition, it happened, it's not your fault. Second thing is to say to them, we understand that is a very hard condition, as Kate mentioned. It's a condition that's there with you all the time. It's a very frustrating condition because you could be doing absolutely everything right and your blood sugars are still high and you're sort of saying why. And people can get so frustrated with it that they can give up on it. And we would ask not to give up on it because there's help there for you. And the help, as Kate said, is education, to give you a skill set to try and help you understand why the sugars might be high or low, what to do when the sugars are high or low, how best to manage it. Then we also have huge advances, as we mentioned, in pumps and technology that are there to help people. And if you are feeling down or fed up or frustrated, ask for help because there's help there for people. Just ask for it. For type 2 diabetes, again, for type 2 diabetes, it is about just a healthy lifestyle. It's a healthy lifestyle that we should all be trying to implement in all of our lives, and to sort of say that there is huge advances in the treatment there, where the treatments are so much better than what they were maybe 10 or 20 years ago. And to stick at it, and again we recognize it's frustrating, again we recognize it's hard, again we recognize it's there every day, and occasionally having the odd break, having let go for a few hours, that's okay. That's okay. Because, you know, it is a very difficult condition.
That's great. Thanks for that, Dermot. So any other thoughts from Seamus or Ed?
I think Kate and Dermot have really covered it very well. I think, you know, there is so much in terms of technology and monitoring and treatments available now. They're only as good as the ability to engage with them. And we know it's hard, but that's the most important thing, I think, to tell the individual, you know, there's lots of help there for you. You have to put a little bit of work in yourself, and that will pay off in the long term. We know that.
Yeah, that's great. Thanks. And really it's about using the supports, particularly through Diabetes Ireland, but also what I'm hearing is that things are changing all the time. So make sure you keep in touch with your healthcare team as well.
Yeah, and keep hope. Keep hope because it's getting better. The progress is amazing when it comes to treatments. So just keep your hope. It will be better.
And like, I mean, as we said, the treatments are evolving and changing all the time. And in fairness, the Irish state has been fantastic at allowing people with diabetes to get those access to treatments, and we want that to continue. So that's something that has to continue, because it is making a massive difference to quality of life.
And I presume in Ireland it's possible for people to get access to research trials that are testing new treatments.
It is, yeah. I'd say in the last 5 or 10 years that has become a bit more challenging. You know, 10, 15 years ago, it was much easier to get clinical trials up and running in the hospitals here in Ireland. I think part of the problem is now that the pharmaceutical companies are looking elsewhere so they can get trials done very quickly, for instance, in the Far East and China and places like that, Eastern Europe. Maybe the regulation mightn't be as tight as it is here. You know, and of course, clinical trials have to be tightly regulated. There's no question about that. But I think the ability for the pharmaceutical companies to recruit very, very fast in other countries means that we're getting fewer trials here in Ireland. But you know, we have a diabetes clinical trial network here in Ireland now who are actively advocating to recruit more trials, because I think it's fantastic. I've probably been involved in about 40 plus trials, clinical trials in diabetes, and it's been fantastic for our patients. It's been fantastic for the team. It gets you to learn about new treatments before they become available and actually to offer those to your patients. So I think it's something we really do need to pursue and to get those trials back into Ireland to the way they were 20 years ago.
That's great. Thanks very much, Seamus. Okay, so we're on the home straight now. We're going to finish here with just some take-home messages. So we might just start with you, Kate, and then go around, if that's okay. So what would your take-home message to our viewers and listeners be today?
I think, as I mentioned earlier, just keep hope. It's getting better, although we know it's relentless condition. It's a very hard condition to live with, whether it's type 1 or type 2. Just keep hope. Wake up every day, control controllables, so only what you can control, you can change that, and just live your life.
Great, thanks very much, Kate. Dermot?
Yeah, I'd sort of say, like Kate says, is to really emphasise the point there's help there. A lot of diabetes, as Kate mentioned, is self-management. You are, the majority of the time, looking after it yourself. But there's education and there's technology and devices that can help you manage that more effectively to a higher quality that will reduce complications down the line. And essentially for someone now who's been diagnosed with diabetes at this stage in 2025, I would say the outlook is far brighter than it was previously, and that's fantastic. And I think it's only going to get better.
Brilliant, that's great. And Ed, we'll go to you next.
Sure. So, you know, we've talked a lot about the problem and how complex it is. Seamus mentioned prevention, though, and I'd like to, and I think it's worth reiterating that, is that as difficult of a condition is, it's also one of the most preventable conditions that we actually have in public health right now. And there are many, many risk factors, genetic, lifestyle, what we eat, how active we are, how we sleep, what our air that we breathe in. But for the most part, it really boils down to the big three. And that's healthy diet, being physically active, and maintaining a healthy weight. And as we age through life and we tend to put on weight, the degree to which we can prevent that makes a big difference. So those big three can have a huge effect on what the future looks like for the numbers of people developing this condition. So.
That's great, thanks Ed. And then Seamus.
Yeah, I suppose I'm probably going to reiterate some of what's already been said, but I think compared to 30, 40 years ago when you were diagnosed with diabetes and there was very little really we could offer you, and we couldn't really sit down and say, look, if you do this in 20 years, 30 years time, you can maintain your health. I think now we are at that stage. The treatments that have emerged in the last 20, 25 years are just fantastic. We are at the stage now where we can tell people if you take this medication and it controls your sugar, it will also give you the chance to prevent your kidney disease, prevent your heart disease, all these dreaded complications that people probably have in their mind when they hear diabetes. They think, oh, what's ahead of me is an amputation. We know now that we can prevent those complications. So we're there, and I think that's a very positive message to get to people when they are diagnosed with the condition.
If I could illustrate what Seamus just said. So when I was diagnosed with diabetes, my parents were told that by the age of 20, I'll definitely be blind and I probably won't have any limbs. My mom asked whether I could get pregnant. Absolutely not. So yeah, just to mention, 30, 40 years ago, when you're diagnosed with diabetes, you weren't even sure if you'll keep alive 40 years later, whereas I'm very much alive. I have no complications at all, and I have fantastic, beautiful daughter. So Hannah, and I would like to say hi to Hannah. I don't know, it can be cut, but yeah, just to illustrate how it is, how it was, and where we can be in the next 40 years. That's a matter of hope and fantastic development and research, which we all do here.
So that's a really positive note to end on, so thank you very much for that. So that concludes our discussion today. My thanks to our speakers, Kate Gajewska, Ed Gregg, Diarmuid Smith and Seamus Shreenan. Further details about upcoming episodes in the RCSI My Health series can be found on the RCSI website. You can also find the RCSI My Health series episodes across all major podcast platforms. RCSI is committed to improving human health and well-being. We are proud to be ranked 5th in the world for our impact on good health and well-being. From all of us here at RCSI University of Medicine and Health Sciences, thank you for joining us.